Now, why are bacteria so harmful to wound healing? Well, when you look at this list, it's easy to see that bacteria can consume nutrients, they lower the oxygen level within the wound, they secrete harmful toxins which are starting to digest enzymes and break down collagen and other proteins and growth factors. So it's possible that when you're adding growth factors to your wound bed, you're simply just adding more and more protein that the bacteria will break down if the bacteria are at a critical high level. And also bacteria can stimulate MMPs, which are detrimental to wound healing, as we all know. And this slide just shows that bacterial inhibition is constantly trying to fight and lower the wound healing response, as we said before. Closed pulse irrigation will enhance the wound healing response by decreasing this bacterial inhibition. And as bacteria become more and more severe and drug resistant, as bacteria become more virulent, it is all the more reason that we should be using CPI to eliminate bacteria from the wound bed. These levels of bacteria can reach critical levels. Certainly when you're first injured, there's just simple contamination. As we see here in stage 1, a contaminated wound is not suffering from an overburden of bacteria. Therefore, it will heal. However, as bacteria build up within the wound and become colonized, the wound will start to heal more slowly. And certainly at stage number 3, which is called critical colonization, this is where the wounds are neither healing and they're not getting better, they're not getting worse. And this is due to the fact that we have reached a level of bacteria greater than 10 to the 5th organisms per gram of tissue. What that means in real life is if you perform a skin graft, it will fail. If you perform some type of muscle flap, it will fail. And overall, the wound will be non-healing. These are patients that suffer from wounds for a period of weeks to months to years. And of course, the infected wound is the wound that we all know about. It's red, there's a spreading cellulitis, and generally these wounds are going on to be admitted to the hospital and are treated with IV antibiotics. But we can really intervene is within these pressure ulcers. That's where CPI is most effective. And the reason we need CPI is that we need mechanical hydrodebridement to remove the biofilm. I know that for many of you, this is the first time that you've seen this slide, and this is a scanning electron micrograph of bacteria living on the surface of a wound. Many of us have been taught that the bacteria will live as if they're living on a petri dish. Well, the truth is, this is more what the biofilm is all about. And this is a very new concept in wound care. And why is it important? Because this biofilm is actually a protective shell-type coating that is preventing topical treatments such as antibiotics or silver dressings from being effective. This defensive mechanism is what protects the bacteria and prevents healing. And this is a Scientific American diagram of bacteria forming a small colony on the left, which then starts to grow and become a more advanced, complicated biofilm. And it is within this biofilm that antibiotic resistance is developing. It's within this biofilm that a very extremely adherent interface is forming on the surface of the wound. And it's because fluid can freely flow through the biofilm that it is very difficult to remove with topical dressings. However, with the pressurized treatment of closed pulse irrigation, we can remove the biofilm selectively from the surface of the wound. And what we're seeing here is a wound bed covered with biofilm, depicted in yellow. The antibiotics, which are given to the patient IV, as you see, cannot get to this biofilm because they're just not making it to that bacterial interface. And so during each CPI treatment performed by a therapist, and this is why it is a therapy, during each treatment, this yellow biofilm has to be completely treated with the CPI, and it will disrupt the biofilm and remove it from the wound bed. So the therapist is actually communicating with the patient during the treatment. The therapist is actually directing the treatment in order to cover the entire surface of this wound. As I said, we're introducing CPI as a daily treatment to remove the bacterial biofilm, and it will in fact remove MRSA from the surface of a wound. It will in fact remove yeast from a yeast infection from the surface of a wound. CPI, as I said, is selective in that you will not be making the wound bigger in order to make it cleaner. You can selectively remove dead tissue from the wound bed. It is a bedside treatment performed by a physical therapist, and due to the total containment of our system, we have eliminated suction, which greatly eliminates pain during each treatment. And it is used now in many JCO hospitals and subacute nursing facilities, clinics. It's used in home care and by the U.S. military. So what's happening when we pressurize fluid and apply it to the surface of a wound is, if we were going to take a simple IV bag of fluid and pour it on the surface of a wound, we would generate approximately 1 pound per square inch of pressure. That would be not enough pressure to really do anything to the wound, to the surface of the wound. But we can increase that pressure if we use a 35 cc syringe and a 19 gauge needle to spray the wound. And here we're reaching a pressure of about 5 to 8 pounds per square inch. The mechanical pulse irrigator used for CPI will generate a pressure between 8 and 15 pounds per square inch. This is a very important number because we are not over pressurizing the fluid, so we're getting an effective removal of bacteria and dead tissue, but we're not under pressurizing it either. And because it's mechanical, you don't have to rely on your own strength. It is much more reproducible. It is a much more effective therapy performed by the therapist. And I do want to caution you that if in the old days, pulse irrigation got a very bad reputation due to the fact that many facilities were using something called a water pick to irrigate wounds. Although it was the beginning of our whole progression with this new technology, it was too much pressure because you can damage the healthy tissues. This pressure of 15 pounds per square inch is approved by the FDA, and it will not harm normal tissues. What's very important also is that it has been shown in recent publications that you can remove 86.7% of the bacteria from the surface of a wound with one treatment of CPI. And now I'd like to turn this portion of the symposium over to my colleague, Dr. Venturi, who will talk to you about some of the safety considerations concerning CPI.
Good morning. Well, thank you for having me here today. Dr. Marasco covered the problem of infected wounds and the efficacy of closed pulse irrigation. What I'm going to talk about is some of the evidence-based research that supports the use of closed pulse irrigation. If you look at this slide here, this shows the open technique where the operator is irrigating an infected knee wound. And you can see that the operator has the irrigating device, but there's also a basin and suction. But pay attention to the splatter, that is the spread of potentially dangerous infectious material that gets dispersed not only on the patient but also on the operator and the field in general. So with the open technique, there is a real risk of contamination with regard to the spread of this infectious material. So are there any consequences to this? Is this really a problem? Well, absolutely. This is a study from 2004 out of JAMA where there was an outbreak of multi-drug resistant Acinetobacter at Johns Hopkins University. And they linked this outbreak back to the treatment using open pulse irrigation, where they were treating a patient infected with these bacteria. And the consequences were drastic. Actually, 2 people died from this infectious breakout. They also found that the open technique is woefully ineffective at preventing the spread of infectious materials when you do the open pulse lavage. So Dr. Marasco covered the efficacy of closed pulse irrigation and pulse lavage in general, but our question is, how do we take this system and make it safe and prevent the dire consequences of contamination? Well, using the closed technique, that is the CPI, closed pulse irrigation, There was a study that was published in Wounds in 2008, and this study was performed at Wake Forest University, where they took 10 equally infected wounds. And in 5 of the patients, they irrigated them with the open technique, and with the other 5, they used CPI, that is closed pulse irrigation. And what they did is they spread Petri dishes around the patient at 1 foot, 2 feet, and 3 feet. And they measured the amount of colony-forming units, that is bacteria, that wound up on these Petri dishes after they performed the irrigation. And again, half the people were irrigated with the open technique, the other half using CPI. And the results were dramatic. The average number of colony-forming units using the open technique was 30.1. With the CPI, the closed pulse irrigation, less than 1. And this was a statistically significant result. The really interesting thing is that even at 3 feet, remember those Petri dishes that were 3 feet away from the wound, there still was a statistically significant difference where in the open group, the average number of colony-forming units was 13.5, whereas with CPI, again, less than 1. So if you graph these results, it's really dramatic. Closed pulse irrigation essentially shuts down the dissemination of potentially infectious material, making this process very, very safe. And these results were published in Wounds in 2008. This shows the efficacy and power of this technology. Thank you.